Children's Hospital Medical Center, Cincinnati, representing excellence in pediatric healthcare since 1883. Home of major developments and discoveries, including the heart-lung machine, the science of teratology, the oral polio vaccine, artificial blood, new lung surfactant replacement. Today, the largest pediatric facility in the nation, Children's also has the largest pediatric residency training program within a single institution. Through its affiliation with the University of Cincinnati College of Medicine, Children's staff serves as the faculty for the university's Department of Pediatrics. One of the nation's leading pediatric research facilities, Children's today is a major tertiary care and referral center, treating patients from every state and many foreign countries. Its mission is to provide the best possible patient care, education, and research. To preserve our medical history, Children's Hospital Medical Center has produced a series of interviews with distinguished medical faculty. For information on rental or purchase of Medical Heritage Series tapes, please write or call Children's Hospital Research Foundation Library, Elland and Bethesda Avenues, Cincinnati, Ohio, 45229-2899. Area code 513-559-4300.
Today we bring you another videotape in the series of interviews of persons that made Cincinnati Children's Hospital internationally known through their accomplishments. We are recording the history of the institution through the eyes of those who made major contributions. My name is Dr. Janet Strife, and I'm a pediatric radiologist at Children's Hospital. It is my privilege to interview with Dr. Kaplan today Dr. Fred Silverman, who was chairman of the Department of Radiology at Children's from 1947 to 1975, 29 years. And today is a really special day at our hospital because it was the 4th Silverman Lectureship. And Dr. Kaplan, by a committee, was selected to be the 4th Silverman Lecturer. And he came to Cincinnati. The lecture was at noon. We had a luncheon beforehand, and we're sort of resting in the laurels of the lecture and enjoying the memories that we've shared today. Sam, how did it feel, first of all, to be selected as that special Silverman Lecturer?
Well, as you know, the spokesperson for the invitation was Jerry Wyatt, the chairman of radiology at the university. And when he called, I think the only occasion that I was speechless. I didn't know what to say because
That's rare.
it's rare. It's very rare because I've had the good fortune of working with individuals who have done such good work that I've been invited to present their work all over the world, and I've had many accolades. And because of our personal relationship, this is, from my point of view, the acme of my career. Couldn't be better. It's just great.
I think one of the special aspects of your introduction to the lecture was the several remarks you made concerning why being selected as the Silverman Lecturer was so special. And perhaps you could just reiterate those remarks.
Well, it was special for a number of reasons. There were professional reasons, where Fred and I worked together in clinical investigation. We did lots of things together. I remarked on 2 during the introduction to the lecture, but there were only 2 of very, very many others. The first one was when Fred decided that it was time that we would be in the forefront of recording angiocardiography with Cine. So he arranged for he and I to go up to Mason Soanes at the Cleveland Clinic to see Cine angiocardiography. It was a very exciting experience, and we came back bubbling, and we couldn't wait for the equipment to come. And Fred has the honor of being one of the first demonstrators of syneangiocardiography at a national meeting of the American Pediatric Society. I'll never forget that experience, because the patient that he showed was, one of the patients that he showed was somebody with pulmonic stenosis. And you saw the right ventricle eject, and you saw this mushroom-like cloud appear over in the pulmonary artery. And the audience was really hushed by it. And you could sort of, it's the only time I've been at a national meeting where you could feel that they wanted to see it again. And Fred could feel that too, so he showed it to them again. He reversed the movie and showed it to them again. And the other thing I commented on today was the excitement of Fred's with bringing in whether the brain was in the center of the skull or not. And as I said this morning, he saw a box which said, "Do you want to order an electrocardiogram?" And he asked my advice. I didn't know what he was talking about. I said, "Sure." And that started the careers of so many echocardiographers, not only in this country but abroad. It's the beginning of all of those wonderful times. I just want to reiterate one other thing, and that is that in 1952, we did the first open heart surgery in Cincinnati. And Fred was in the operating room to record this. He and I had seen the child before. We made the wrong diagnosis. We thought it was an atrial septal defect, but it was a defect between the left ventricle and the right atrium. So that, but nevertheless, he was there, and he recorded this thing for posterity. So he's been a part of all my clinical investigations. It was great. And then, let me take another second or two. Our personal experience was also great. As I said, we have been together to 23 states, 11 countries, and we've shared a lot.
But only 2 wives.
One each. Which I think must be a record as well amongst radiologists and cardiologists. Certainly in Los Angeles it is. But so those are the things that the early parts that I talked about.
Well, it makes us really good individuals then to have been selected to interview Fred, since we've done
Sonography into Cincinnati in those days to get the A mode to find out whether
all the talking here so far. But I was a student of Fred's, and remember coming to interview when I came as an intern with Dr. Weech. And Fred's sort of been my mentor and helper along the way, to which I'm very grateful. Let's go back to the early years and start out in Syracuse. Like you finished your training and you got your Bachelor's of Arts at Syracuse, and you stayed for your MD degree, and then you went to?
Well, I went to Yale to work with Dr. Powers in pediatrics. And that was really one of the great things for me. It was a very fortunate thing. In those days, you applied for internship. There was no matching program. You had to get in early. And invariably, the place that you didn't want to go to was the one that answered first and said, respond in 24 hours. And you had to have a lot of guts to not respond, or else you did respond. And I remember what happened. I was actually a substitute. I was a first alternate at Yale for pediatrics, because they took the people right out of their class, mostly. And I was sort of thinking, well, I still have Boston in January, where you had to take examinations to get in. And there was still a chance there. And then I got a telephone call one day that one of the boys who took the job had changed his mind, was going to Hopkins. Asked me if I would take the job. Well, there was only one answer I could give. And it was a great thing for me because, excuse me, at Syracuse we had a clinical school. I think that's probably what has put me a long ways into that field. The, excuse me, our orientation was clinical. I wanted to do some research during my holidays. There wasn't any going on. A professor of physiology who I wanted to work with said, well, we're closed. So I had good clinical training, and when I went to Yale, I knew nothing about some of the laboratory work that was being done in the advanced schools. I figured, well, in 3 months, maybe I can learn it, or at least have 3 months to have the experience before they kick me out. And one of my co-workers who had been in the class at Yale had written a paper for the Yale Journal on carbonic anhydrase, and I didn't even know what carbonic anhydrase was at that time.
Could you spell it?
Here was a guy who published a paper, and that frightened me even more. But I got along reasonably well. I felt I knew what I was doing, working with the kids and listening to what was going on. And about 2.5 months into the situation, he and I each had a kid with acute laryngotracheal bronchitis. We had a steam room where we put the kids that time. And we didn't have any real thing to treat them with, so we gave them the steam primarily. And this fellow was very much concerned about his patient. He said, I'm going to call the ear, nose, and throat resident because I think my kid needs a tracheostomy. And I said, well, you know, that's a terrible thing. It's awfully hard to keep track of. You know, why don't you try some Ipecac? He said, what's that? So I said, well, it's in the formulary. I was busy. You know, look it up. You know what to do with it. So I took care of my kid, who wasn't as sick as this other fellow's kid. And in the morning, we had to be there at 8 o'clock, having written up everything, done all the lab work, and make rounds with the professor who would ask the questions, and we would explain what we had done. And the professor asked this fellow, he said, tell us about this child. He came in, he gave him an excellent description of what the child had, the stridor, the retractions, and everything else. And then he said, we were going to do a tracheostomy, and then we decided to give him some Ipecac, but he vomited it. I figured, I don't have to worry anymore. And I didn't. I had a great time there. And then when that year was finished, I took another internship, this time at Hopkins, because I felt that if I spent more than 1 year in one place and didn't learn what they were doing and how they were doing it, I was wasting my time. And Dr. Powers was very kind to get me a job at Dr. Park at Baltimore. And that worked out very well. And then I went on into pediatric pathology because I wanted to have a little opportunity to evaluate the clinical experience that I had and what I thought I knew.
Well, when did you first become interested, the thought that you might pursue in radiology?
Well, that was after the war. See, the pathology fellowship that I had at Columbia was interrupted by the war. I went down on, I think it was December 8th, to apply for a commission, even though I was a class 2, didn't have to go in. But we felt pretty strongly about things in those days. And I left in February, and I was overseas almost immediately in the South Pacific. Came back in December of '45 for supposedly a year in the States, and I was up in Boston working as a pediatrician to the 1st Surface Command. And then the war was over, and I had enough points that I knew I was going to get out fairly soon, so I had to say, you know, what am I going to do now that the war is over? I have to look forward to things. And I was really thinking of practicing pediatrics, but it so happened that just at that time, Jack Caffey's book came out, the 1st edition. And I had known Jack from Columbia, because he used to come up to the path lab to see what was going on with the patients, and I used to go down to look at the x-rays down in his department. And I knew that any good problem case would go through the x-ray department. And I thought that would give me the highest concentration of seeing what had happened in the 4 years, 3.5 years that I'd been away. So I wrote to Jack and asked him if I'd come down. It was a one-man department. He'd never had anyone before. He said he'd check with Rusty McIntosh to see if they could pick me up. And Rusty said, well, we've saved your money that you didn't use on your fellowship back in 1941, 42. So you can start out with that, and we'll see what we can do afterward. So I went down, and on a GI Bill for 6 months, I started working with Jack. And within a very short time, I knew that that was what I wanted to do, because I thought I had fairly good training, but I learned so much every day that how could I think I had been educated before? And,
looking back on radiology, it's a really special field, isn't
no
it?
question.
Because it just offered continued growth and continued learning. But one thing I really agree with you on is that you really have a concept of what's going on in the hospital. And there's, I mean, they use imaging, all of the services use imaging, and it uniquely puts you in the, of learning about many different aspects.
Yes, you learn from your other clinicians about other clinical fields, but you still have to work, I think, from the clinical aspect if you're going to be a clinical radiologist. I remember, you've heard me say this because I've said it to almost every fellow who has gone through the department, that I've been with Jack 6 weeks when he was going away for a week, vacation. And he said, take over the department. It was a one-man department then. And, I couldn't do it. I knew that when he didn't have anyone before, and I was his first, that they used to get one of the chief residents or one of the junior staff people from Presbyterian to come over and look at the kids' x-rays. And I said, don't you want them to do it? No, no, he says, you've had pediatrics, I can see that, and you'll do better than those fellows will. And if you have any problem, call them, they'll be able to help you, but I trust you. Well, during the week that he was away, we had a horrible epidemic of bronchopneumonia. Case after case of bronchopneumonia, for which I was the etiologic agent. I was afraid to call a chest normal. I've learned since then. But I've tried to teach that to other things, If it's not there, don't find it. Don't look too hard, or you'll find what you're looking for.
Janet, could I interject just one statement? The fact that you had this pediatric background,
Yeah.
and that Janet had the pediatric background before you went into radiology, I think may make both you guys special, because the current trend is to go from medical school into radiology residency.
Mm-hmm.
And I think that you people both had the opportunity of working with patients. Not only that, but it's one of the few radiology departments that I saw when I was in Cincinnati where the radiologists were actually examining a patient.
That's right, I had my stethoscope.
Right.
Now you get a rectal exam once in a while.
Yeah.
Well, I think that's the name of the game. Radiology is diagnostic radiology is a clinical field. It is part of physical diagnosis, physics applied to diagnosis, you say. And I look at it. We learned inspection, palpation, percussion, auscultation. That was a sequence that we learned. I look on diagnostic radiology as perspection, a subheading under inspection. And this is Jack Caffey's teaching to me. He said it was as logical for a man to put on a blindfold, or a woman, put on a blindfold and go up on a ward and percuss the patients and suggest a diagnosis. It's true, you might find a liver that seemed large, or you might find a heart that was large, fluid in the chest, tympanitis. There'd be certain things that you'd find with percussion. But the idea of making a diagnosis and at one modality was ridiculous. But it's exactly the same concept if you sit in a dark room with films in front of you and you don't know anything about the patient and you make a diagnosis. From a logical standpoint, it's the same thing. And I think that it was Jack's concept that I merely have continued and have enjoyed continuing, try to teach to the people I've had.
Well, let's move to coming to Cincinnati and how that all came about. Maybe you could both reiterate. And,
This too
was there a lot of mental debate about moving and big decision, or was it an easy decision?
It was a fairly easy decision. In those days, having been in the service, you moved without any problem whatsoever, But this was also an offshoot of Jack's book, because when his book broke in 1945, all of a sudden, children's hospitals who did not have radiologists who were trained in pediatrics realized they needed people to go to various hospitals. And Jack, of course, being the outstanding person at that time, Ed Newhouser was been in Boston about 2 years at that time. Jack was getting letters asking for people. He said, there's nobody there, we have nobody training. He said, there's just one person who's training with me now, but he won't be ready for another year. Well, Ashley Weech had been at Columbia previously, before he came out here. And he and I had worked together in teaching some of the stuff on hypersensitivity disease. No, the not thalassemia. What am I talking about? The
I was going to say rickets. But
no.
rickets.
There was radiology in it, but it was the blood disease, the monkey factor.
We're not doing well.
RH disease.
RH disease.
Right.
That's
Okay.
right. RH disease. You should have started asking me this question 10 years ago. I might remember better. And Ashley and I had worked on that to try to persuade the obstetricians at Sloan Newborn at Sloan in New York that this was an important thing and you had to study it. You know, and this was the cause of the icterus of the newborn and the various forms of it. So that I knew Ashley. Ashley knew me. He knew Jack, and he wrote to Jack. And when Jack said that I was there, he said, "Well, I'd like to come visit him and see maybe he'll want to come to Cincinnati." And he did come. We had a very nice visit. And he said, "Why don't you come out and look at Cincinnati?" And Jack said, "By all means, go." By that time, I'd had another offer of what seemed like a greater job, but a lot more money. But Jack said, freestanding children's hospital, and particularly Cincinnati, is a place where you'll get the greatest opportunity to grow. So I went out and looked at the place, and that was the time that Ben and Joe Workin, he gave me some tests, without telling me about it, and it apparently came off all right. And so they were satisfied, and he then offered me a position, and he solidified it by saying, "Well, you're just working on the GI Bill right now. Why don't we give you $75 a month to help you grow?" And that made all the difference in the world. So when I finished with Jack, I came out here very happily, landing in Lunken Airport because the big one wasn't here, and had a wonderful, wonderful career and home here, and great friends.
So Dr. Felsen was, I'm not clear, like right now we're sort of hired from the university, but at that time you'd be hired from the university by Dr. Felsen, and yet you'd work over at Children's?
Things were not as organized as that. No, actually, I was hired by Children's Hospital. They provided the funds, and he who pays the piper, calls the tune. And they were providing the funds, and the only thing that was needed was to have the approval of the radiology department. Now, Ben was not chief at that time, but he was working his way toward it. And he was quite satisfied. I mean, after all, Ben was an open-minded guy, if there ever was one, and support anybody who was willing to work. And he gave me all the support I ever needed, and really pushed me. He gave me promotions in radiology ahead of the ones I got in pediatrics, because Ashley was more not rigid, I won't say, but more follow the rule.
Sam, when did you come into this picture early?
Well, I arrived in Cincinnati in 1949, in September 1949. I was recruited by Bob Lyon, and I thought that they were going to pay me a magnificent salary. The reason that Bob Lyon knew that I existed was because my brother was here at that time on a fellowship, and he was working on the second floor of the research building with George Guest and those individuals. And when I arrived in 1949, I was met by my brother, who at that evening had a statistics class. And he wanted to know whether he asked Fred whether I could eat with he and Carolyn. So my first meal in Cincinnati was at Fred and Carolyn's home, and she was sort of upset about this because nobody had told her about it. And all she had prepared was leftover meatloaf, which was great, having come from England where things were, so it was great to be in a home.
And if you remember that night, we went to a party over at Dick's, and after...
As a matter of fact, I had 2 eggs. But it's so, it was, those were great times because we knew we had one objective, and that objective was really to gain new knowledge. We really wanted to learn. And we had a lot of fun when we discovered something.
And we shared it.
You bet.
We shared it.
I was so impressed when I came out here because traditionally radiology and cardiology departments are at each other and you don't share because somehow you feel that they're going to get ahead or they're going to take. And I remember when Dr. Silverman interviewed me and I said I was interested in cardiovascular radiology, he said, well, we have one rule. He said, the departments will get along. If you don't abide by that rule, you know, don't come. But how did that develop? I mean, a lot of departments developed along different tracks that you were working on projects together and it wasn't competing for funds was different. I mean, this is really a unique instance where you had radiology for years. Radiology and cardiology got along because that's the way it was.
Well, we didn't work to try and do it. It just happened.
Yeah.
It's, we had one Polish egg a week, which had been on the ocean for about 2 or 3 weeks. I think that Fred recognized the great potential of imaging with X-ray. And we were at a time where the stethoscope and our eyes and ears were very important, but we were slowly bypassing it. The reason I went to London before coming to Cincinnati was to learn about that new tool called the cardiac catheter. Very exciting thing. And I arrived in Cincinnati at a time when opportunity was great, and people sort of just opened up their doors, whatever you want.
Yeah.
And Fred was one of those major people because...
Well, I needed somebody, Sam, who knew cardiology. We did. We're done routinely with surgeons.
I must say, I'm just so... the first time when the catheter was in the heart and you injected contrast, I mean, was that just like the Bengals winning?
Well...
it was exciting.
It was scary.
Sure.
It was scary.
Really? Why do you say
Well,
that as a response instead of a...
Because I was scared. We had... You went ahead in those days with very little experience and very little direction. You can't do that today. Wisely. But we were treading a relatively uncharted thing, so on. And I was scared stiff of arrhythmias, the catheter being in the heart, and so on. And it was frightening but elating when we got these things. Now, our initial films that we got, over here with Ben Felsen, we had a long tray that we had 4 or 5 great big cassettes in. And we did that with Teddy Muha over here, the little kid with the AV fistula. And you'd get ready to do the injection after the catheter was in place. And then you'd push the stuff in fast and yell, shoot! And the technologist would stand there. One technologist would push a film in place, the other one push the button, and you push another one. These were all cut films that we were doing. And then I saw a device that came from Palo Alto, and you had a crank that you cranked them through as fast as you could. If it didn't jam, it worked out fine. We used those films.
You could increase your number of films per second to get the motion of the heart.
We could get 2 a second then. That was something.
I was scared, as Fred was, because there were certain problems that were at great risk. In those days, if we had somebody with pulmonary hypertension, if we put in the contrast, was it diadrast? I can't remember the name of the stuff.
I think it was.
That people with pulmonary hypertension had a great risk of dying, and there was acute pulmonary hypertension. But a thing that I'll never forget is that we had a little guy by the name of Jimmy Pickelheimer who had tight mitral stenosis, and we'd do cut downs, and when I was scrubbing his arm without putting in a catheter, he died. And that was one of the most frustrating of me. It was he who realized what I was going through from the point of view of this child with tight mitral stenosis dying, even though we had not done anything to him except put him down on an X-ray table. It was so that, it was not only pulmonary hypertension, there were other factors that happened, but it was together. Those things that we'll never forget. But his comfort, that we worked. Fred has no problem remembering Jimmy Pickelheimer because it was sort of a brother-like comfort. Certainly not looking at me with a fatherly view. It was much more a brother looking at a brother, taking you through a problem. So those early days, yes, we did have problems.
And a whole institution in those days, too, was one where you shared ideas and concepts and work with others. It was a wide open, everybody help anybody else, anybody would pitch in. George Guest was great on it. Joe Workany would come around and give us information, and the surgery, even surgery, would give us help. Lots of help. Jim was great. Eddie McGrath was the first one I worked with.
Well, let's move a little bit and talk about the abused child. I know everyone, you're recognized for your contribution with the abused child, but I'd like to hear you restate those early observations you made. I know in your talk this morning you always underplay your role a little bit in the recognition of that syndrome, but
I think that's a proper assessment of it. The recognition really began with Jack Caffey. I carried on the work, and as I said this morning, fools rushing in where angels feared to tread. I laid it on a line about there being inflicted injury. I didn't know enough to be concerned about any legal action in saying that, and Jack was concerned about it, although he felt he was the one who taught me that. And subsequent work has supported it and proved it. And I think that the great interest really developed, as we showed on that graph, when Henry Kemp coined the term the battered child for that symposium on the subject that we had in Chicago, the American Academy of Pediatrics meeting, roundtable.
let's just go back a little bit before that. I know, Dr. Caffey, when you were there, you'd seen some of his cases.
Oh, yes.
So I wanted you to and then right after that, it seems like you came to Cincinnati, and then you here observed a case, and I think the films are still in our teaching file of the very cases that you published.
Exactly.
And what led you, Dr. Caffey's teaching, but also you must have had a strong intuition, and then you pursued it clinically. I mean, you...
No, I think it was the visual aspect of the bone lesions, and my interest at that time was largely in the skeletal lesions and learning more about the bones. It was a very unusual type of bone reaction, and I wanted to know more about it. Not only know more about it, but I was waiting for something to show up like that and to say, hey, this is what it is. And I think it was just a matter of awareness and looking for some. Same thing when I got interested, for example, in calcification of the intervertebral discs in children. I started looking at the spines very, very carefully as they came through. And I found dozens of cases of calcified intervertebral discs that I'd missed all the time because I wasn't looking for it. And so as these kids would come through, they never had a history of child abuse or child battering or anything like that. Some came in just because they had a respiratory infection, for example, and we found the lesions in the bones at the shoulder, and at that time I was free to form consent necessary to us at that time, and so I could get other films and immediately establish that here's a child who was at risk. And as I kept finding them, and particularly going around to meetings, doctors would come up to me with films and say, is this what you reported? And I'd say, yes, that's the same thing. I began to realize it was a big problem, but Henry was the one who recognized how great it was when he circularized the district attorneys, judges, hospitals, and so on, about the number of cases of known child abuse, and found that there were so many that something had to be done. Go ahead and take radiographs of anything else there. We didn't have the infant. That was just the tip of the iceberg.
Radiology plays a unique role in that syndrome because at the same time we can identify the x-rays in court and suggest the diagnosis that someone has abused the child. But I think that you certainly have encouraged and stimulated radiologists to be active, but also to be cautious. I remember a couple years ago a talk misdiagnosis or misuse of paper. I'm blocking on the title of the paper, but
Yeah.
Emphasizing of how we should be, it's destructive to report children that aren't abused.
Well,
as
what
abused.
you see in the radiograph is a result of injury, and that's why I personally like the term unrecognized trauma, because it's not pejorative. It's not a bias as soon as you say battered child or child abuse. We can say, yes, these are lesions that indicate that there has been injury. Now, if the history does not explain that type of injury, then you have to say that, well, that injury has been inflicted, the information is being withheld, or it has been forgotten, or was accidental and not recognized. But the lesions that you see in a child who's been abused physically can be identical, as I showed you in that last case today, with children who get lesions because a father saved the kid from a fall by grabbing them by the legs, and in doing it had the same type of pulling, twisting force. Custodian takes a child by a limb and pulls him up and throws him or something like that. So all we can say is there's injury. We can't say the exact nature, although we can say in the things to be considered, and if you see the fact that there are multiple lesions, that they're of different ages, then you know there has been repetitive injury, and that makes you more hot on the possibility of child abuse.
Do you have any thoughts about legislation which has come about these in the various states about child abuse relatives?
That cause the trauma, the battered child situation, and the child with a parent or the custodian.
To those individuals who have been falsely accused?
Yeah, I think there's something that has to be done without really changing the law. Every state and all our outside properties like Virgin Islands and so on have laws that are very much the same, patterned after a law that the Children's Bureau suggested shortly after our paper came out, and we had a couple meetings on it. The problems that have arisen as a result of it, though, is that many zealots will push any child as being child abused and immediately want to take a child from a family, and sometimes you have to because a child can be at great risk. But I think there has to be a great deal of circumspection in it. I don't mean necessarily delay, but circumspection and not labeling the family particularly. At the beginning, when we talked about how to handle the law of taking care of children who are abused, and it was not to be punitive on the parents necessarily. I mean, if a law had been broken that way, if it was a crime, criminal law took care of it. This was juvenile law. The point was that you had to report it so somebody could do something about it. And many of us wanted to report it to social service agencies because we felt there was a closer feeling of family reaction than police. But it was pointed out very clearly that the only people available 24 hours a day, 7 days a week to do something about a situation like that are the police people. And the police, by and large, have learned a great deal about it, and they're very careful in most cases. But still, there are a lot of people who are unjustly accused of child abuse. And I am concerned about the radiologist overreacting to these things because of the pleasure we get out of seeing something that we think we can recognize in a film and calling it child abuse. You can say there's injury, and rather than prejudice of people immediately.
I was going to ask about some more skeletal dysplasia. Is that okay?
Oh, God.
Because just one question about skeletal dysplasia. In the many trips that we've done together, somehow or other, you have been able to find that statue that you've taken pictures of, which have recorded over many centuries the skeletal dysplasias. I can, in Paris, it's unbelievable what you've taken pictures of over there. But there are many cities in the whole world that you've gotten these things. How does it get your attention? I mean, when you're walking down the street, how are you able to find that thing amongst all those little gargoyles around about the place?
Well, there are certain patterns that individuals who have abnormal bone growth can follow. And once you get used to them, you know, it's how do you read EKGs? You get used to certain patterns. And this is really a sort of a gestalt type of situation. The dwarfed individuals who have the unusual bones, unusual faces, and so on have been known for thousands of years. In mythology, you have dwarfs. Loki is often considered a dwarf. Hephaestus, the god of fire, is a dwarf with a club foot, maybe metatropic for all we know, or a diastrophic dwarf or rather. But names have been applied to them, and it's interesting, but only to some people. I remember giving a very lengthy discussion of dwarfs and the radiologic signs of dwarfism to a small group of us. I think it was in the Catholic Society. And after I finished giving a very careful discussion, Ed Singleton said, "Oh," he said, "I've had dwarfs up to here."
Oh, that's good. Like one of the, at the Silverman lecture today, they emphasized that between the two of you, you've had 125 fellows. And
I don't know. I think
sounded like
I
a
think
lot,
we
but
multiplied it. We've had a fair number, though.
Well, I know how many I trained in Cincinnati. I can give you their names, addresses, and the total number is 68. So
Well,
Fred,
And
yours
we
is
would get-
48. I
Yeah.
think it's
So
48.
well, it's over
it's
100
around
then.
there. There's a Silverman Society that our group of former fellows enjoys getting together, and it's medical. We go over cases and learn from each other. And I've always liked the format of that, where you say, look, I made this mistake, and this is how I made it, or this is something new I'm thinking of, and it was sort of your style. But can you talk about some of your fellows? And
Shall we talk about Janet?
no.
I've been very fortunate to have interested people and very capable individuals who've come to work with me, and I think they indicated their interest and their capability by the fact that they did come to work, because the stipends that I had available were much less than the stipends that were available elsewhere. And so obviously they felt that they could get something here. And I tried to give them every opportunity to grow and develop, because as they grew and developed, they taught me things. And it's a reciprocal relationship all the time. You know, when you work with the medical students, they teach you things. And it's a two-way street.
I think one of the big messages you taught me as a fellow is the imaging isn't always the answer, which comes again to the physical diagnosis.
That's right.
And your concern about radiation. It all goes, but you know that you need to, what's the clinical problem, what's the setting, and how can we approach this? And I think sometimes you're disturbed as I am when the CT, MRI, ultrasound, barium enema, and IVP are all ordered without considering what is best. Is that...
Yes, it does bother me. If you remember, for a long time, I used to have the requests, and you remember what I did on the page? I called them consultation requests, not x-ray requests, consultation requests, because I wanted people to feel that we were consultants in the same way that other specialists were consultants, and that these requests were scanned by our people in the department before the technician got them, instead of the technician just getting the request and going off and doing the exam that was asked when it was the wrong examination for a particular thing. In fact, when it was an examination was not needed, but a lumbar puncture was needed and not a skull x-ray. So I tried to keep it clinical that way. And some of the older people will remember. When I first came here, and I was all alone, in fact, I had to do a lot of typing myself, I couldn't type the reports, lengthy ones at all. And when people came in with examination requests, because they tell a technician what they wanted, and I say people, I'm talking about pediatricians, orthopedists, urologists, and so on. An examination was taken, and I knew about it when a film came across my desk. If there was no clinical information with it, I used to send back a report that said, please state the clinical problem when requesting x-rays. That was the only report that went back. And some of the people got very, very mad They came up to see me. When they came up to see me, I sat them down and talked, told them what I was trying to do. And these people who got very mad were the ones who became my strongest supporters. They would call up and say, look, I've got a kid who's got this, this, this. Is there anything that you can do in X-ray that can help me out in it? Which was the way I thought it should be. And, but with today's situation, we can't do it very well.
You were talking about the fellows a few minutes ago.
I think I distracted Fred.
It's,
You did.
and you said it was a two-way street. It was a two-way street for cardiology as well, because Fred may not remember this, but he helped many medical students at the University of Cincinnati getting through medical school by letting them be night X-ray technicians. And the night X-ray technicians gave all of us the opportunity of working with these guys. So when George Nagao or Dwight Turey or many of the others were X-ray technicians, and we got to talk, their interest in cardiology,
John Parton.
Their interest in cardiology grew.
That's right.
And so he helped me recruit many of the fellows.
But that wasn't anything I did. I just did it as part of what was a hospital policy. Because
Yeah.
they did hematology, they did minor biochemistry, and we brought these good students in, students who could afford to take time off at night from their work. They were going to be good enough to get through medical school. Learn these various procedures and do them at night because we didn't have night technicians.
Well, but still, they were.
Oh, yes, they were great.
Picked
They
out,
were great.
and they are great.
Yeah.
Still.
Who are some of your other special fellows? Of course, that's a bad question because you might leave someone out.
Oh,
but,
I'm sure going to leave.
I don't mean it that way. I meant,
Well,
but the first, John Dorston was there, or
yeah. Well,
who you sent me to work with for a while, which I was grateful. And who else
yeah,
was there?
Barry Gerald,
Barry
who was the
Gerald.
department chairman. Lionel Young, the department chairman. Bill Smith,
Bill McSweeney at
Sure.
DC
Bill McSweeney,
Silverman's,
Barry
sure.
Potter. Yeah, we've had a great gang, and Janet Strife, too. All professorial rank.
Did you say Hoosh Taby?
Hoosh, of course, one of my best, one of my early ones. Yeah.
You know, I admired you for taking Hoosh for lots of reasons, but I think at that time you may not have realized it. In the early 50s, the McCarthyism was going on
We
in
knew
the
it
United
here.
States.
Yeah.
And Children's Hospital felt it with Rappaport Group, and they're having to leave the country because of their communism. And you're one of the few people who took people like me who are foreign medical graduates. And these guys in those days were considered to be communists until disproved. So well, that was my perception of it. But I think that there were lots of individuals that you took around, especially Hoosh, that you gave the chance to do what he did.
Well, that's really the thing you do. You give somebody an opportunity to do what he can do. And if he's got it, he'll do it, and he'll do more.
Fred, the thing I've always admired greatly in you is your humanitarianism, whether it's a people-to-people, an interest in how a person is doing, and not only their work, but their social environment. And I speak personally on that you ask about my family and about how things are going and so on, as well as professionally. And, you know, I see in medicine a change. Everything is getting big. I think interns and residents earn more money, and they don't have the closeness that I went to Sam's house many times and your home many times, but it's different. I'm not sure it's bad that it's different. It's just really different, and perhaps we were all fortunate to be.
Aristotle said it, nothing is permanent but change.
Right.
Yeah.
Well, if you could be reflective about your years here,
Well,
you
they've been
sum
great,
them up in
wonderful
a-
years. It's awfully hard to sum up as much as we've had here, other than to say it was absolutely superb, rewarding, and I couldn't do it again right now because the circumstances don't exist that existed when we started. But I think that you people who are doing it now deserve a tremendous credit for doing it, for recognizing what you have to do, what you want to do, in the face of all these things that face you. think you're the heroes.
Sam, do you have any last parting words on this 4th Silverman Lectureship Day, in which you've had a very special day, and I certainly have. I've enjoyed talking to you both, but do you have any special comments?
I didn't have a chance to comment earlier on the humanistic things that you've just been talking about, because with Fred and Carolyn and Molly and I, it's been closer than a family. We sense when each other needs help. We get it. Molly and I have my brother in this country and his wife, and that's it. When Fred and Carolyn were in Cincinnati, we went to them with any family problems that we had to get advice. At the time of
Sometimes we gave it to them when they didn't even ask.
Yeah.
That's good family for you.
At the time of the second Silverman lecture that John Kirkpatrick gave, when we had that special party at our house that I showed the slides of this morning, was the week that Molly and I had to make a decision as to whether to go to California, having been in Cincinnati for 37 years. And, I asked Fred, what should I do? And, of course, he said, you have to make that decision yourself. I can't make that decision for you, but, when we live at Stanford, this is what we do. And, he helped us greatly. It's a big decision. I honestly hope that all people have the opportunity at the twilight of their careers to have the opportunities that Fred and I have had to go to a place that welcomes you, that respects you,
And
gives
let
you an
you work.
And let you work.
Yeah.
And
You do what you want to do best.
Exactly. And I sincerely hope that everybody has that opportunity, because that would be my major comment about the Silverman lecture, was the humane part that Fred has shown us.
Sam, I think that this is something that the institutions really have to learn to do, is to make use of the older people who want to work, who can work, and who can do things, and are not going to be a tremendous drain on them, but in fact can serve as role models and do a lot of things. There's a lot of people being wasted because they can't get jobs.
Since you are left-handed, are we going to have a good president?
Kinder and gentler one. Well, that I can't help with, Sam, any more than I could help you on making your decision to go to California.
Oh, I forgot to mention about the library. And I know that you were chairman of the library for many years. And over there in the library, and your important role as the editor of the Cafes now, the last 3 editions? Or,
No. Well, I've worked with, I worked behind the stages on Jack's book since the 60s, but officially with him in the past 3, you're right.
Now, you donated those books to the library, did you?
Yeah. I gave them, remember, in memory of Louise Sias, had been a librarian when I was chairman of the library committee.
Oh, that's great. That's great. Well, I wanted to thank you. I love the fact that you're wearing your tie, because your bow tie was tradition when you were here, and it's real special to have my pleasure to talk with you today.
Pediatricians' formal attire.
It's the bow
Kids can't
tie.
grab them. Kids can't grab it like that tie.